Hi, everyone. Welcome. Welcome back to Misconceptions. I am excited to have a wonderful person here with me today. Her name is Emily. Emily, I don't even know if you want to use both last names, one last name, but welcome to our podcast, Emily Markovic.
Schlussel Markovic.
Russell Markovic. There you go. And we are so happy that I'm so happy that you're willing to speak with us today to have this conversation. Welcome to the podcast.
Thanks, Dvora. I'm excited to be here. You know, we've been talking for a while, but I don't think there's anyone else I would do this for but you. So thanks for having me.
Okay, thank you. Thank you. So I think you're probably the newest mom that I've had on this podcast. Congratulations on your newborn, and you are actually 6 weeks postpartum right now, right?
Yes, yes.
And how are you feeling? Let's start there. How are you feeling?
I'm feeling great. I'm very lucky. I've now two very precious, beautiful little babies, and well, not twins. Toddler and a baby. But I'm thankfully it's been a good recovery. I'm feeling good and going back to work soon.
How much maternity leave do you get?
I have 8 weeks off, so I have two
Okay.
more weeks.
Okay. Yeah.
I
Look,
worked
we can
until the
talk a
last
little. Oh
day.
my goodness. We'll talk about that. So, Emily, why don't you tell everybody who you are? Tell us about yourself personally, professionally. What brings you to our podcast?
Absolutely. I grew up in New Jersey, in Teaneck, and I eventually, after a very indirect route, ended up going to medical school, and I now am doing fellowship in maternal fetal medicine after completing obstetrics and gynecology residency. So I guess I've always had a lot of interest, both personally and professionally, but I'm feel very grateful to have the professional journey that I've had, even though it's taken a little longer, doing a post-bac and going back to school. It's the challenge that everybody has with juggling personal, family life as well as professional life. And it's, at this we'll get into my journey, but I'm very grateful to have this challenge and this struggle that I've tried to get to that place for a long time. So I'm glad to be in that club.
So, tell me something about your medical training. Where did you go to medical school?
I went to Mount Sinai on the Upper East Side,
Okay. And then you did your
Manhattan. For
OB.
those non-New Yorkers listening,
Okay. In Manhattan. And how many years of residency is it for OBGYN?
4 years,
And then after that is how many more years for maternal fetal medicine?
3 more years.
Okay. And what year are you in now?
I just started. I'm in my
You
first
just
year.
unbelievable. You said you took a break between OB and MFM?
No, I was not pre-med in undergrad. So I worked at
Oh,
Microsoft after graduating and I did a post-bac in order to apply to medical school and then worked at the New York State Department of Health doing quality improvement work while I was applying to medical school.
wow. Okay. So you've been in school a very, very long time. Got
Yeah.
it. Okay. And then what made you make that decision to switch into medical school? Like what pushed you in that direction?
I had always had an interest in health and medicine. I think partly growing up, I was diagnosed with a chronic health condition when I was a kid. And so I think part of me felt like I didn't want my life to be surrounded by medicine and I had other interests. And so I pursued those in college. And then after graduating, I was working at Microsoft and just realized that as honestly, it was a great, fairly cushy first job. And my husband was more interested in what I was doing than I was. And I was always a little envious of my friends who were pursuing paths in health and medicine. And so I made the leap. I ended up leaving that job and doing a post-bac, actually at Bryn Mawr College, which was, a
Oh,
1 year post-bac program, kind of uprooted my newlywed life
wow.
and then the rest is history.
Wow. Okay. So I want to talk a little bit about the reason that I've invited you onto this podcast is your fertility story and also the complexity of what it means to have a chronic medical condition and going through fertility or attempting to become pregnant, create your family. Tell us from the beginning, did you always know there would be difficulty getting pregnant or okay, so just talk to us about where this began.
Sure. Yeah, not necessarily. I never really had a menstrual cycle. And so I thought there was always a possibility that that would become a challenge. But um, my mom got pregnant easily. My sister got pregnant easily. I think deep down, really thought it would be an issue. And so it was, anytime I got advice, I was told, just try and you'll see. And that was, those were thoughts well before I started trying to actually conceive. Um, the kind of chronic medical condition started getting involved where I was married for, a number of years and starting to think about, starting our family. And I had, some medical issues that were not consistent with pregnancy. And so I was told you need to treat those before you'll be kind of medically cleared to get pregnant. And so even though I didn't have infertility, I hadn't even tried to get pregnant, I already was starting to feel some of that pull of I want to be pregnant, I want to have a family, and I can't do that right now. So I think it did have some overlap with some of the feelings that, and maybe exacerbated some of the feelings that I later experienced when I did try unsuccessfully to get pregnant. And so when I did start trying to get pregnant, I basically just came off birth control and never got my period. And so I started fertility treatment almost immediately. Thankfully, I was well plugged in. And at that point, I was a third year medical student. And so it was, it's for those not as familiar with the path, the medical path, it's the year that traditionally is the clerkship year. So people are doing rotations in various medical specialties. Every movement, everything about you as a medical student is being judged. So the residents and the attendings that you're working with are evaluating you, grading you. That goes into your grade, which ends up being what you take with you to apply to residency. And, if you're expected to be in a lot of places at once and to, have a great attitude and smile all the time and do all of the things that, need to be done or nobody wants to do. And that's really hard when you're also trying to, go to doctor's appointments and have, infertility treatment and not tell everybody who's, doesn't know you, but is evaluating you what's happening in your personal life.
Can I ask you something? One of the things that I think about, I know when we go through fertility difficulties, one of the things related to treatment is the amount of hours that are really not your own, right? Really defined by, I have to be at this place, at this lab, at this hour, for this blood draw, for this procedure. It's almost, to me, feels impossible to do that when you are part of a medical team or you're part of this, your training in medical school or even in residency.
Yeah.
How did that play out for you, like interpersonal? How did that work? Because I know that as much as, we have rules and we have some, by the way, locally there in Philadelphia, I don't know if you've heard this, but Philly is trying to launch a union of residents. Like the residency programs are actually trying to unionize, which might make a difference, but ultimately doesn't really make a difference because on the ground, the expectation is, like you said, you're going to be there at multiple places, smiling, happy. Like this is not going to impact, that doesn't matter. Like what matters is your training. So what was that like for you on a
Yeah,
practical
I have a
level?
lot to say on the union topic. I actually was a union delegate during residency. It's the same union nationally. So we can talk all about that.
Oh boy.
Lots to say, but yeah, it did feel impossible to me too. At the time, so being a third year medical student is a very different role than being a resident. Um, you know, medical students, and I think about how to say this in a way because I definitely, medical students are an important part of the process. They're an important part of the team. And as someone interested and, cares about teaching and the students that I work with, I, don't want to make people feel like they don't matter, but teams can function without medical students. And so in terms the difference
Mm.
between doing it as a medical student and doing it in residency, it was the pressure I felt as a medical student, but people were not relying on me. So that was
Okay.
a big difference in residency. The service that the residents bring to the hospital is people very much depend on it. Um,
So so as a
was,
med student, like what was that like? Like were you allowed to leave early and be there on time for your 6 a.m. medical appointments, or you really didn't have that flexibility?
um, yes, I would have to either for depends on what how the timing of things worked out. I was able to get excused absences as in the kind of school term
Sure.
for like a medical reason. the team it was tricky though, because the team that I worked with, it's not very centralized. And so the person excusing me is the clerkship director. It's somebody from the school, the medical school. The people evaluating me and writing my grades for my residency application are just the clinicians on the floor, the residents, the attendings,
Mm.
and they don't know what's happening. And so I had to choose really every day, every encounter I had to choose what to disclose, who to disclose it to. If I wanted to just try to, do it all and, not draw attention to the fact that I had to be somewhere else at a certain time, and just try to make up for it by working really hard and doing a really good job and, trying to help people give me the benefit of the doubt that I wasn't just slacking off and being lazy and just being absent, but I actually care about what I'm doing. I care about my education. I care about the patient, and I just do have to be somewhere else
Yeah.
at whatever set time. So it was definitely tricky, and I felt like I was walking a tightrope much of the time.
I can imagine that.
And it
And
was
so we,
exhausting.
yeah, and you don't get very much sleep either. Right. Okay. So when you are, so you go, you begin, I have to comment on the idea of not having a period that you said you never got a period. I'm wondering if that's something that, kind of, were you given any information about that growing up? Was that a feature of a chronic illness or that had nothing to do with it? And like, I'm just wondering medically if somebody is experiencing that, like, what would you like them to know about not getting a period?
Yeah. So this is like the OBGYN and me speaking versus the
Right.
like person remembering my childhood. But I would say on the personal note, my aunt is a gynecologist. And so I don't know exactly what happened. I wasn't completely informed, but I know that I had blood work done. My aunt was guiding my mom, and I had a gynecologist that I saw, and they did some workup on me that I don't know exactly what it entailed, but I think was told everything was hormonally and structurally normal. And at age 16, I was given medication to induce a period, and we kind of moved on with my
Went with
life. It
life.
wasn't
Okay.
it wasn't an event in the sense that it wasn't like a medically something that I focused on. Socially, because I was a very open kid, it was something that somehow my entire grade knew, and it was like this big joke that we had that like Emily didn't have a period.
Wow.
Very strange when I think back, but medically, I would
Actually, I
say,
think it's probably very typical. I think it's
oh
very
yeah.
typical that these are the things that are being chatted about, depending on the culture of the community that you're talking
Mm,
to, but absolutely something that is going to be discussed. Yeah.
yeah, makes sense. Medically, I'd say, there's different causes of primary and secondary amenorrhea. Um, I had primary amenorrhea, which is I never got an initial period. But, definitely an important thing if you're, to assess if somebody is developing normally in terms of breasts, body hair growth, making sure that they're otherwise developing normally. And if those other things aren't developing, they'd want to see their doctor sooner. But certainly, if everything else is developing normally and they're still not getting a period as they're, I'd say even just not that you necessarily do anything at 14, but I think it's good to check in with the doctor before you would medically intervene.
Right.
And so they're like, something a pediatrician should be checking in on, but it might be time to see a gynecologist. And there's really amazing pediatric and adolescent gynecologists. If there turns out to be an issue, there's great people to see
There's guidance.
who
Yeah.
can help and address whatever the underlying issue is.
Yeah. Yeah. I think it's just important to notice it's not one of those things that we just kind of like, oh, no big deal. It is something that has to be paid attention to and medically addressed. Okay. So you're in your third year of medical school. You're going to begin fertility treatment. Tell us what goes wrong or what goes right.
Sure. So I started with, ovulation induction, which makes sense. I didn't have a cycle. I wasn't ovulating. That's really the natural first place to start. And so what that looked like, I saw a reproductive endocrinologist, just kind of clumping together a very long story, Clomid and letrozole, which are ovulation induction agents. I did monitor cycles, so I'd go in for ultrasounds in the morning before I'd go into the hospital, see if I had any follicles growing that could, that eventually ovulate and lead to a pregnancy. And then initially started with just timed intercourse to try to conceive. And then eventually that progressed into intrauterine insemination, IUI. Um, and we did that a lot. We did at that point 6 cycles, and it wasn't working. And actually, the first cycle that I did a trigger shot. And keep in mind, this is before I was an OB/GYN. I didn't really know
Right.
anything about this process. And took a trigger shot, and then I was told to take a pregnancy test at a certain time. But of course, I was dying to know if I was pregnant. My first cycle, I fully expected this to work the first time. And this was, I didn't have a period. Now I ovulated. Of course, I would get pregnant. And so I took a pregnancy test early, and it was positive, but not because I had my own intrinsic beta HCG from a growing pregnancy, but because I had taken a trigger shot. And so I don't know exactly when I realized that positive was actually not a positive and I wasn't pregnant, but I just have a memory of completely falling apart. And it was, and when I think back, because it was such a long journey for me, it took me about 5 years from when I actually started trying to get pregnant to have my daughter, which is after, almost 2 years of wanting to try to get pregnant, but I wasn't able to. Um, and I just fell apart. And when I look back at, what the beginning is like, and I later felt like I somehow had, earned a badge or I don't know what but that like I was in this veterans club of people who had been trying forever. In the beginning, oh, it's just the beginning, but really the beginning is hard and it's painful. And already from that first cycle, it was just like the despair of like, wow, that didn't work. I don't have the future that I thought I would have.
Yeah.
So that was really difficult.
I think we want to address also the fact that I hear your professional trajectory, right? That person who's, working at Microsoft and then steps away in order to go to medical school. Like you're the kind of person I have to believe that if you put your mind to something, you accomplish it. And being in a situation which feels very much out of control, like, what do you mean? I have a period, I'm ovulating, I'm going to be pregnant. And that like huge like backlash of, wait, what do you mean it didn't happen?
Mm.
Tell me a little bit about what that emotional experience was like.
Yeah, it definitely. I mean, it definitely got worse as I progressed through my infertility journey. But it was. I definitely had various identity crises throughout. Partly what you're describing exactly of, I've in the past been successful. If I put my mind to something, I've been able to do it. Even, of course, I, have had failures and disappointments, but then I was able to overcome them and get to the next stage. And, this wasn't working. And no matter what I tried, it wasn't working. And I, it definitely felt very hopeless at points, very frustrating. Um, I didn't know how it would end. And so, there was a lot of just, darkness on the horizon, which was something that was very scary and very painful. And the other aspect of the identity crisis is actually, it's not what you're asking about, but I was always somebody who was very, ambitious, very career driven. When, sometimes I would speak to people who, what do you want to do when you grow up? And they would say, I want to be a mom. And I would, in my mind, like, oh, like, I want to be so much more than that. I want to have a career, and I want to do this and I want to do that. And I got to the point during this infertility, process where all I wanted was to be a mom. And that really shook me also, because I went from somebody who was so proud of all these, ambitions and goals that I had to like really feeling like they didn't matter. And that actually what mattered was becoming a mom. And so that also really shook my identity, because it was hard to know who I was if I, didn't really have the interests or the passions that I previously had.
Oh, okay. I just need a minute for that to sink in because I feel like I think that's incredibly insightful, but also really gives me a moment of pause of I have to bring up this question that I have. It's something that I feel like I sometimes soapbox about, but I feel like sometimes we're sold as women this bill of goods that we can do everything, right? Meaning we can have this career, which is so admirable and such hard work and so much dedication that's needed in order to become a physician and become a physician plus a specialty, right? And then and I know that you weren't pushing off your fertility, your experience, but I think sometimes many women do by circumstance, right? Like I just got to make it through medical school full, and then I will begin to grow my family. And I'm not talking about specifically religious or Jewish women. I'm talking about women across, I think, the world, but definitely United States, right? And I sometimes feel like we're not fully acknowledging this struggle to become parents might take much a different path than you. It's not necessarily on your timeline. And as there was a very old fertility book called A Few Good Eggs, and the whole book was about like your eggs are getting old, right? Like the eggs, we don't have an unlimited fertility experience. I'm just wondering if you want to talk with me a little bit about that, like the story we are sold as maybe it's feminist, maybe it's just educated, maybe it's just like empowered women of you can do anything. And then to hear you say, actually, it reached a point where it didn't matter. And what mattered was for me to become a mother in these moments in time. What was that like for you, right? Talk about an identity crisis, but also, I guess I'm seeing it also from this other experience of like, we're selling a story to women that you can do it in whatever timeline you want, and but it's not always true.
I hope that's changing, what you're describing, that, I think there's becoming more awareness of, that there is a biological clock that women shouldn't or maybe can't always put off, their reproduction for, indefinitely. And also fertility preservation is becoming more accessible to people. And so I do think people are talking about, and it's becoming more socially acceptable to discuss and to go and freeze eggs, whether people or embryos, whether people are, looking for a relationship, have a relationship, and just aren't ready to start
Sure.
a family or, whatever it is. I definitely think it's being talked about more, and people are starting to get either insurance coverage or more commonly companies offering it as a benefit. And so I do, and certainly professionally, I do talk to people who are thinking about, starting I don't even like the term starting a family because people have a family even without children, but
Agreed.
people who are thinking about reproducing, having children, biological children, who are thinking about it in some, vague way as they're reaching their upper 30s or even 40s. And, I do counsel patients all the time that it's something that they need to, think seriously about. If this is important for you, that, it would not be wise to push it off, but, to start the process as soon as possible, if, at those
Yeah.
ages. And it's really hard because we all know that, in the United States, there really are not the supports that women need to be able to do it all.
No, not
The
even a little bit.
like maternity leave, lactation, childcare. I mean, we don't have any of it
Yes.
established in this country. And so, careers do take hits, and, there aren't enough hours in the day to do it all. And so people have to make choices. Um, and it's hard because people's priorities are going to feel different at different points of their life.
And I think that is definitely the honest truth, right? Like things can change, even if you don't expect them to, but they can change. Once you realize that things were not working, what was the next step for you?
So the reproductive endocrinologist who I was seeing initially for those ovulation induction cycles doesn't do IVF, and so she referred me elsewhere. I ended up going to, at the time, I thought convenience was really important for the reasons that we've discussed. That it was really, really hard with balancing my, professional school life with my fertility treatments and appointments. And so I chose to start with an REI clinic, an IVF clinic that was the closest, most convenient location. And also, I did not have any insurance coverage at the time. And so this was all costing a lot. I had insurance coverage, not that it just excluded fertility.
Right.
We can talk all about that, but
Oh, yeah.
it was costing a fortune. And this IVF clinic also had the benefit of being a little bit less expensive than what IVF would have cost at the other clinic I was considering. And so started the process. We made embryos, so did an egg retrieval cycle. I did at some point in there get the diagnosis of PCOS. And so as often people do with PCOS, I was a very strong responder to all the medications. And thankfully, I didn't, making embryos or having eggs was never my issue with it all with all the infertility. And so I ended up being a little bit hyperstimulated, having a very large egg retrieval. We made embryos and we were ready to go with IVF. And then, unfortunately, that medical complication that delayed the whole process to begin with reared its ugly head. And I was told I could not get pregnant again for the foreseeable future. And so I was not able to actually transfer an embryo and try to conceive again. So that was a major blow after, what we felt like, we got to the point we were going to do IVF and that was just going to be, that was going to be it. It was going to work. That felt like the disappointment was going to be that we had to do IVF. Like that was a drag, but that was supposed to be the end. And it very much was still the beginning.
Were you counseled in terms of saying, like, look, you have this medical condition that keeps on showing up and keeps on being something that is putting a stop on treatment. Maybe you should consider using a surrogate. Like, was that part of the discussion at all at any point? Because you were able to create embryos.
It was, it was not. I think so. We did pursue a path with a gestational carrier surrogate. It was not something that was suggested to me. I don't remember, I guess I, was aware and thought of it. I don't remember exactly how the idea came to pass, but I think I am, healthy enough that my physicians all felt like, that pregnancy wouldn't be an issue. It was more the pain of infertility and waiting and wanting desperately to have the children in the family that I wanted. And I don't think that's something that any of my physicians really understood in terms of that pain. And so I think for them, it was you'll wait. And then at some point in the future, you'll be able to pick this up again, which was really not an acceptable option to me. And so at that point, my husband and I just decided that we were going to find a gestational carrier and take the embryos that we had just made and, conceive and, transfer an embryo into a gestational carrier and have our child that way.
Okay.
It's not as straightforward as the plan.
No. Okay. Tell us what happens.
So there's different, when having a gestational carrier carry a pregnancy, there's different ways of finding a carrier. There are agencies, people also just, find somebody on their own, or there's something called an altruistic carrier, which is somebody who's not doing it for money. They're not doing it through an agency. They're doing it out of the goodness of their heart. We were very, very fortunate that Josh's sister, my sister-in-law, was willing to carry a pregnancy for us, which is really an enormous thing to ask of someone. So I even, obviously, I carried my own pregnancy. I'll give the giveaway at the end, but even just the fact that she was willing to do this for us is something that will touch me and affect me forever. I mean, truly a huge thing. And so we went through the process of setting up this gestational carrier relationship, which is really complicated. We needed to get our embryos kind of retroactively cleared because we didn't do certain sexually transmitted infection testing initially, since this wasn't the plan. My sister-in-law, as a gestational carrier, needed to be medically cleared, psychologically cleared. We needed to be psychologically cleared. She needed to be obstetrically cleared. It's a very long and difficult process and expensive process. Yes. And then at the end of all of it, you need to have lawyers, both for the gestational carrier and for the intended parent, and to have a contract.
Can I assume this was all taking place in New York State or New Jersey?
We lived in New York State.
So, I mean, New York State really only surrogacy by definition, right, only became legal very recently. Was this before that or after?
It was before, for the most part, but my sister-in-law actually lives in the state of Illinois, so
okay.
So it was not.
We weren't. Got it. I bring that up because I think it's important for people to realize it's not legal in every state. And so therefore, like sometimes these contractual agreements, it doesn't mean it can't happen. It just means that some of these contractual agreements will need to take place in another state and then transferred back to New York in terms of like what they call parentage. So just this idea of it's just one more hoop to jump through. New York State, it has become legal. In many states, it is now becoming legal, which we expect to see a whole lot more GCs coming up and these arrangements happening in New York State. And I think they're kind of scrambling to be like, how do we do this the right way? But
Yeah.
I was just curious to see if there was another hoop that you needed to go through. Yeah.
It was actually very cool. My last year of residency, there were two gestational carriers who delivered on our labor floor while I was there. And I definitely felt a kinship just to them,
Sure.
and very different, we as a labor floor, as a community in New York, don't know how
That's
to
right.
handle it well. And so we don't have the language, we don't have the processes to make people feel comfortable yet. And so it's definitely, there's a lot of growth and learning that has to happen in states where it's becoming more common but isn't yet.
Yeah, because it's not like you just train one group of people. You got to train every shift, and even just like the rooming in or rooming out of the intended parents, of the biological parents of this child. Like there's a whole lot that goes into the sensitivity of them welcoming this baby, into their lives, that is very different than typical OBGYN care. Yeah.
And the only reason I knew about this was because of my own personal experience. It was not part
Yeah.
of my
Yeah.
training. It's not really on the radar for most people until it comes
Right.
up.
Right. Exactly. Okay. So you made it through almost to the end, and then what happens?
Um, we started transferring embryos. We went with three. I mean, this all obviously took a lot longer, and we did a lot of testing trying to understand in between. But we transferred three embryos, one at a time, and all three cycles failed, which was really surprising because this was somebody who had, easily, conceived and birthed her own beautiful children, my niece and nephew, and these embryos were, chromosomally normal and were high grade, and everything was supposed to be perfect. Her uterine lining looked good. Like there was no explanation for why this wasn't working.
Yeah.
It just wasn't working.
Yeah.
So that was
I just
another major blow.
yeah, I mean, to me, it just sounds so devastating. Like that
Yeah.
you've gone to the extreme option, right? You took even that did not succeed for you. Yeah.
Right. It was a lot of like, first we didn't conceive naturally. So sex makes baby was out. And so we started the fertility treatments. And there's some, you're giving something up. There's something a little bit sad about medicalizing the process. And then we went to, okay, that didn't work. We're going to do IVF. And that felt like a little bit of a loss, but okay, IVF, that should work. And then I'm not even going to carry my own child. And that felt like a huge loss. And that was
Yeah.
something I really struggled with. But ultimately decided, my rational brain won. I want to have a child. This is the way it's going to happen for us. We are very lucky to have somebody willing to do this for us. And so I know this fetus will grow in a beautiful environment with a beautiful person. And that wasn't working. And so, even though I had felt each time I was giving these things up, it was okay, but this was going to be it. We were going to have a family. It just, again, failed and failed and failed.
Yeah. I got to ask as a therapist, like, tell me about your emotional state going through this, because
It
you're
was bad.
also and you're also managing medical school. And at this point, are you in residency?
At this point, I'm
Yeah.
in residency, which OBGYN was not the original plan when I was starting out in medical school. And I guess when I was choosing it, I hadn't really gone very far down this infertility journey. So I can't say that played a role in the choice. It kind of interwove, I guess. But at this point, I'm in residency. Now it's COVID, which
Oh,
also complicated things because my sister-in-law who lives in Illinois couldn't travel to New York where our embryos were. We had to have our embryos sent to where she was because traveling was very complicated. Support
right.
persons being present was very complicated. It was really, um,
They weren't allowing anybody in the room. I think we should be very clear about that. Hopefully this podcast lives in posterity. And like, we want to remind people that, the patient went in the room and nobody went in with them. And the
yeah.
spouses and partners and support persons were literally in the parking lot. and they were not allowed to have anybody at their bedsides going through treatment. And I would say that, at least from my understanding, is that that was one of the fertility clinics were the ones that kind of held on to those rules for a bit longer than general medical population. Like the
Mhm.
general medical world kind of opened up allowing somebody else with them in a medical environment, right? Going into a doctor's appointment. But fertility clinics held on to that restriction for quite a long time longer. And so this aloneness is very, very profound for the women who are going through infertility care.
And in gestational carrier world, it's even more tricky because there should be a support person. There should the intended parent should be allowed in the room for the birth of their own child, but also the gestational carrier should have their own support person because
Right?
the intended parents, even if it's your beloved family member, they can't be your support person and also
That's
focus on the
right.
birth of their. It just doesn't. It just isn't fair. That they need to have their own person too. So it became really tricky.
Yeah.
We never got to that point. We never, were in a
Right.
birthing room with a gestational carrier because she never got pregnant with our child. But it was, definitely we had to think all of these things through with lawyers and,
Sure. Sure.
and just figure out what it would look like when, if, and at the time we assumed when we got to that point.
Did you want to continue doing transfers at this point, or three was the number for you and saying we need to stop this?
I think it was a kind of a mutual decision between all of us, myself, my husband, my sister-in-law, my brother-in-law. This isn't working. It was a lot to put her through. I mean, she was right. Like we talked about how time-consuming fertility treatments are. She was, was starting her own business, has two young children, has her
Yeah.
own family, her own life. And also at the time we were very private about what we were going through. And I think that was also something that was really hard on her, to be going through this huge thing and not really be able to talk about it with the people in her life. And
Mm,
so it was a lot to put her through. It was, felt like we were wasting our embryos. There was something going on that this wasn't working. And we had these precious, embryos that we wanted
sure.
to become our children. And so it just felt like this wasn't working. We needed to find a new route.
Okay. So I do want to talk a little bit about what it means to be an OB, right? To be doing this as an OBGYN, even just a resident, but like it doesn't matter. You're doing the work. What was it like for you watching these women having either baby after baby or like unintended pregnancies or teen pregnancies? Like it had to have been incredibly difficult exposure of the way that the world, quote unquote, should work and isn't working for you. What was that like?
Yeah, it definitely. It in some ways brought me closer, I think, to patients that I understood a lot of what they were experiencing. Not everyone experiences different things, but it gave me a level of empathy that I otherwise may not have had, would not have had, um, with patients going through difficult pregnancies, patients going through difficulty conceiving. Really, I think any experiencing hardship gives us more empathy to understand someone else's hardship, even if it doesn't line up exactly. And so I think it helped me with relating to certain patients. It also was extremely painful and felt like salt in the wound when I took care of, other patients who were making what I saw to be really bad decisions, putting their children at risk. Leaving against medical advice during when they, really needed to be delivered because the baby was in jeopardy. And I
Mm,
was, stuck thinking like how, like I would be a good mom. Like I would make the decision for my child. Like, why is it that I don't get to be pregnant? I don't get to be a mom when people, making what I considered to be, an irresponsible decision or a negligent decision,
mm.
um, just got to have sex and have a baby, and it just like that was very painful. The other thing that I have such a strong memory of, a patient who was, in the office for a routine OB visit, had a very, healthy routine pregnancy, and she was screaming at me because I wouldn't let her, not I wouldn't let her, in the office policy, her partner was not allowed into the room for her doctor's appointment. he was there supporting her, but in the waiting room, because it was COVID and support persons were not allowed in the office, they were trying to minimize exposures. And so while she had this support, he couldn't be in the room while she had this doctor's appointment. And she was screaming at me that she was like a single mom and this was so outrageous. And the like level of entitlement that it hit me so hard that, I'm like, I wish I could be pregnant. I wish I could feel like a single mom the way she's
Right.
describing it. Obviously,
Right.
single parents have many challenges,
Sure.
and I don't mean to minimize that, but it was just really, really hard to sit there and take care of this person in a way, really focus on her and empathize with what she was dealing with. It was a very difficult moment to really not focus on myself, but to be the doctor that she needed in that room.
I jumped right over my question about what it was like emotionally for you to be going through this. I've got to come back to that question. I mean, you're expressing yourself so beautifully about that, but like, kind of zero in on it for me a little bit. What was it like to go through all of this?
It was really, I mean, it was really painful. My personal life really had, like, my social life had really become very small. I felt like I was surrounded by pregnancy. Everyone I knew, I grew up in a Jewish Orthodox community. Everyone I knew was having kids. Many of my peers were on their second or third pregnancy. And, I was still trying to get pregnant with my first. And at work, of course, I'm delivering babies, taking care of pregnant women, taking care of, um, providing abortions to people who didn't want pregnancy, is like, all like doing the full spectrum of reproductive care, while all I wanted was for my personal life was to become pregnant. And that really took a toll. I really isolated myself from many, many friends. And I hadn't necessarily told most people what was going on. I just kind of stopped talking to them, or, just stopped reaching out, stopped seeing people, just because it was too painful. And that social isolation definitely was not helpful. Or maybe it was, maybe that's really what I needed, but it was still really painful, because
Right.
these were relationships that I cared about and previously were really important to me.
What helped you during this time? What were things that you found, okay, this helped me in this space?
The biggest thing was actually I felt really isolated and really sad. And I've tried, therapy. I think that helped. I think that was important. It didn't, I guess do enough, because I felt like no one understood what I was going through. At this point, I had been, dealing with infertility for such a long time. And I felt like the people I knew who had experienced infertility, they did what, I expected to happen. They did IVF and then it worked and then they moved on. And that wasn't helpful to me anymore, because I didn't feel like they understood my journey. And I found this support group, which we ended up calling it the Veterans Group, through Yeshua, which is how I know you, Dvora. And I think that group was really, truly the thing that helped me when I felt so completely alone.
Yeah. I mean, it's what we know statistically that support groups are so incredibly effective for that reason. Like it's a group of people that hopefully are in a similar space in terms of their experience. I think that's what makes it most effective. I think it makes it very complicated though when somebody has the baby in that group and then the group kind of, I find, tends to disband. It's just one of the challenges of support spaces, right? It's just another topic of a conversation. But um, what about extended family, friends? Like, were people were not aware of what you were going through? Was there any, were there any moments where you say, this was so kind? Like this, I'm just wondering if there were any friends or family who said the right thing, did the right thing. I think it's always important for people to feel like, oh, okay, I could try doing that with my friend or my family member. Is there anything that sticks out to you?
I'll answer the question, but I think embedded in the question is something that was, I think, particularly tricky. But the I don't think there was anything that by itself made such a huge difference or changed anything for me. But just knowing that people cared when I shared with people, that they just responded in a way that let me know they were thinking about me. I had people who sent me, cookies or a blanket or just some like a little care package, just something to say like, hey, I know you're going through something really hard right now. I'm thinking about you. And I think that didn't matter what it was, but just something to know that I wasn't completely alone, I think was helpful.
Mhm.
Um, you say like, friends and family being supportive. Family was actually something that was a really difficult place for me because I, have always been really close with my family and they've always been the core of my support system. Um, but in my family, everyone was getting pregnant and having babies. And it was a I think, particularly difficult that the people who I wanted to support me and lift me up during this like time of pain were, doing the thing. Obviously, of course, they're going to have the families they want, but doing the thing that caused me the most pain, which was getting pregnant and having babies in front of
Right.
my face when I couldn't do that. And
Right.
seeing, seeing my family um, as kind of this other, like the thing that is hurting me, the thing that I can't have, was I think especially painful to not be able to turn to my family as the support system that I always had.
Yeah, I think that you're highlighting something that is very is so complicated and also so common that family they'll say, but we want to be there for her. We want to be in support, and yet they can't because just by identity, just by circumstance, it's not the right fit for support at this time.
Mm-hmm.
And how difficult that is because I think some people come to it from a compassionate place. I just would like to be, and then but it's not the right time and not the right space. So when we're talking about you've now gone through the gestational carrier route did not work. And medically, where were you at this point?
I was getting to a place where I might be able to soon be able to get pregnant. So
Okay.
I finished this course of treatment that I was doing and did some negotiating with and was able to get cleared to get pregnant. And so we brought our embryos back to New York. Started with a new reproductive endocrinologist. So this will be now our fourth reproductive endocrinologist on this journey, and started to try to get pregnant again. Because everything takes so long, first we did a couple more ovulation induction IUI cycles while we were trying to move our embryos back, and then started again with, and not, I mean, started again with IVF, but this was the first time that we were transferring embryos into my uterus. We transferred two embryos one at a time, and they both failed. And at that point, I was like completely done with this set of embryos.
Yeah.
And even though we still had many more, I was insistent that it was time to make new embryos because I couldn't possibly explain why all of this wasn't working. Two different uteruses, the linings were looking good, embryos were looking good, like something was going on, and the only thing in common were this batch of embryos. And so I did another egg retrieval, made new embryos, and then at that point transferred, and all this is taking a long time, obviously, but transferred an embryo into my uterus, and that became my oldest daughter.
Wow. Wow. Okay. I want to come back to that idea of it must be that the embryos are bad. Like, can you do that with me scientifically? What is that? Right? It's
I
is
can.
it's not, right? And yet I have heard this from multiple clients or patients or people like that it was a bad batch. What do you think? What's the theory on that? No
I
theory.
have no idea. I have none. I mean, I still to this day explain it. It must be that batch of embryos. Since I had my daughter, we decided, to have another baby, and we transferred one embryo from the new embryos that we made. We transferred an embryo, and that's the baby I just had. I mean, I was
Wow.
2 for 2 on the second batch of embryos, and it was 0 from 5 out of the first, and two different uteruses. I mean, it just
Right.
math.
Right.
I have no other explanation for something we could have identified where we could have known it, looking forward.
No, right. And in
Everything
theory,
else,
and in retrospect, there's no retrospective on this. Like, is there any data? Is there studies related to like sometimes the batch was bad? Like, what do we have no idea.
not that I've seen, not that any of my REIs have been able to identify. I mean,
We don't know why.
I don't know.
So interesting. It's so interesting because you're not, like I said, you're not the first person I've heard about this. And yet it's like, I'm just wondering what the working theory is. It is like the medium was bad. Is it the tech? Is the skill that was, we have no idea.
No
Right.
idea.
No
They
idea.
do, there is data that there's, certain REI clinics, certain embryology labs have better outcomes. And that,
Sure.
goes to the SART data, which is very flawed because, where do you draw, where's the denominator? Who are you selecting for your patients? Are they equivalent, are they, how high risk are these patients? How bad are their infertility? I mean, there's a lot of
Wait,
problems with
wait,
that
wait.
data.
We have to explain this because it's important
Okay.
for people to know what SART is. So go ahead and explain what SART is. You'll do it better than me right now. Go ahead.
So START there's a platform with publicly available data that basically demonstrates how reproductive outcomes are in different embryology labs and different reproductive infertility clinics. So if you compare, two different clinics that you're considering, you can actually look at this data on the website, SART, and you can, see, well, this clinic, has a better chance of having a live birth than this clinic. And so therefore, maybe I want to go to clinic A. The problem with that data is that if clinic A is so focused on improving their data, their their live birth rate, they might only take patients who they think that they can get pregnant. And if clinic B actually has a better embryology lab and it's more skilled and, more, whatever, have better, they might actually have better outcomes because they're taking higher risk patients that clinic A would never have considered. And so therefore, they're actually, their data might reflect that they have a lower live birth rate or lower pregnancy rate, but in fact, they're taking on harder cases um, and be, having more
More
successful outcomes.
successful. Right, exactly. I mean, I know that there are certain clinics that I've interacted with where they'll say like over the age of 40 or 41, they will no longer use a woman's eggs. Like you have to use donor egg after 42 or 3. Like just that kind of restriction tells you that they're really pushing for a much higher rate of success, but it's very it narrows the population. And then yet with somebody like, let's say Penn Hospital, where their data is a little bit interesting to look at, but they are going to be getting some of the more complex cases relating to infertility. So you are right in that the data is curious and also not clear to understand as a layperson.
And I
Yeah.
felt that exactly that experience with two of the clinics that I went to. The first clinic that I went to where I made that, initial batch of embryos, um, they definitely made me feel like they were doing me a favor, taking me on as this like high risk patient with this complex medical history. And like, you're lucky that we're taking you. And the second clinic or not second, well, really fourth, but the one that I ended up having that, gave me my two daughters, it totally felt different. I mean, they just seemed to take the patients that walk in the door and they're going to do their best for you. And it felt like a drastically different experience as a patient.
Exceptional, exceptional. All right. So as we're wrapping up our conversation today, as much as I love chatting with you, I'm wondering, first of all, I want to just check in with you medically. How did your medical condition impact pregnancy, or did it?
Thankfully, I had a healthy, successful pregnancy. Impacted minimally, I would say. I've been really, I think pregnancy actually worked. Getting pregnant didn't work well for my body. Pregnancy actually worked well for my body, and so I'm grateful. I had two good pregnancies and deliveries, and
Wow.
yeah, very
Wow.
very fortunate in that regard.
And I guess before I get to the question that I ask all my participants in terms of like what are some of the misconceptions that you want people to know, I do want to ask about the aftermath of infertility. I mean, you're only 6 weeks postpartum, but you do have an older child. And how old is your older daughter now?
She's 2 years, 4 months.
Okay, so you have two little ones at home right now. Um, what does the aftermath feel like for you emotionally?
With time, it feels. I think I wear my infertility differently. It um, it's not something that is like not front of mind anymore. It doesn't impact my day to day anymore. Um, when I was, agreed to do this podcast with you, which is not something I could have or would have done, a couple of years ago. I had to, start thinking, I was actively, think about, what was my experience? What do I want to share? It wasn't something that had I done this podcast, even though I didn't think I had the emotional bandwidth years ago, I wouldn't have had to think about it because it was on my mind all the time. And so it definitely um, affects me differently, but it's still there. I would say it's not something that ever really goes away. I think it's something that will affect the way I deal with, friends, patients, anyone who's going through something hard. Um, I still, when people make pregnancy announcements, it still hits me in a different way of like, of course I'm joyful for people who are, having good things happen in their life, but there's still a piece of me that hurts when someone tells
Sure.
me they're pregnant, which is actually, I mean, you're going to say that sounds normal, but that sounds kind of crazy to me. That
No, not even a little bit. And I think that it will surprise you as time passes, the things that people will say or just naturally say that it will hit you in a way that you go, "Ooh, I totally didn't see that one coming."
mm,
I know that for me, one of the comments when people say things like, "Oh, is she your youngest?" And that comment can hold a very different meaning for different people, right? For
yeah,
someone who they wanted that to be their youngest, yes, that's their youngest. For someone who there was failed cycles or a lack of, inability to access treatment or the decision to stop, that comment, which is so innocuous, holds a certain power. And I think that's what the aftermath looks like. Like the aftermath will look different 6 weeks postpartum than it will 12 months postpartum. And that experience is one that I think is the kind of the residual, not necessarily damage, but injury that I think
mm,
needs to be acknowledged. Yeah. Yeah. All right. Talk to me about misconceptions. What are the two or three misconceptions you want people to know?
sure. One, I would say, the one I just kind of touched on, so I won't go into it, but just the idea that people with infertility all of a sudden don't have it anymore when they have babies. I think it's a common misconception that I know has been talked about before on your podcast. And, it stays with you in whatever way it stays with you. I think people live with their life experiences forever. And so I'll leave it at that. But the others, I would say maybe more specifically to being both a fertility patient and a reproductive physician. Um, I would say there's the idea that a doctor and a patient are like two separate entities, that they're kind of completely othered from each other. And I think that's a misconception in a couple of ways. But one is that, the doctor can be a patient too. And um, people make, all sorts of, chit chat with their physicians who are taking care of their pregnancy, oh, do you have kids? Little things that people think are just, happy conversation when you're, happily pregnant, but actually can be really difficult
Wow.
for a physician who's suffering with infertility. And so I think keeping in mind that maybe some of the conversations that you wouldn't necessarily that you might think is a little bit too personal to ask somebody on the street might be a little bit too personal to ask your doctor.
I love
Um,
that. Yes.
so
Yes.
that's one side of it. And the other side, I think, is from the patient perspective. Many patients expect their doctors to understand what they're going through. And as somebody who's gone through OBGYN residency and training, I can tell you that they're really, doctors are not necessarily equipped to take care of, the emotional pain of infertility, of reproductive loss, pregnancy loss, of, just all of the various emotional, really difficult things that happen to women's bodies and especially surrounding reproduction. And so, you know, people can, try to empathize, but many physicians are really, don't have the skills or don't have the experience or don't have the knowledge, don't have the ability to say what you need to say to understand your experience. And so um, I think having the expectation that they will sets people up for disappointment. And
Mm.
instead to, explain, I think my advice would be to explain, or to articulate what it is that you need and what it is that you're experiencing, the same way you would with another individual who you're sharing with about your story, because I think that will help the physician better take care of you and better understand your experience.
Beautiful. Thank you. And I feel a responsibility also then to do education for those doctors, for those nurses, for the people that are the team of people caring for others, how to do it better. You don't have to do it perfect, but to do it a little bit better. So, Emily, thank you so much for being with me, for sharing your story, your experience, and your wisdom. I love seeing you on this side of this story. And congratulations, Mazel Tov on the newborn. And I hope that
Thank you.
you get a few, go get into pajamas and get into the couch and go rest.
I don't know how to do that.
I'm not surprised. Thank you so much for
But
being
truly,
with
Dvora,
me.
thank you so much for everything, for having me, but also for all the support that you've given me along the
It's
journey. I really am truly grateful to you.
it's such a treat and a privilege.